Good morning once again, and thank you for staying tuned to Sunrise at Sea right here on CTV. Welcome to the Twitter Jabs too. My name is Apollo Sarah, and in studio with me is Dr. Jimmy Opigo, and we're going to be continuing the conversation of the malaria vaccine for children that is set to be introduced in the country in 2023. Now with me is Dr. Jimmy Opigo, and he's a medical doctor. He's a public health systems expert, malaria specialist. He's also the manager of the Malaria Control Program and also Assistant Commissioner for the Ministry of Health. Good morning, Doctor.
Good morning and good morning, viewers.
All right. So let's get right into the conversation. Before we start, I would like you, for the benefit of the viewer, please explain what the mandate of the Malaria Control Program is.
So the Malaria Control Program is an agency of government specifically set to lead, design, support the fight against malaria.
Yes.
Towards the efforts to eliminate malaria in Uganda.
Yes.
So all disease programs which government prioritizes, they put a specific program within a department to focus on that area. Like we have a program for HIV, we have a program for immunization, we have a program for TB, we have a program for maternal health.
Yes. All right. So what is the prevalence rate of malaria in the country as of now? Since the COVID-19 pandemic broke out 2 years ago, it looks like all efforts have been going towards, managing and eradicating and preventing COVID-19. But what about malaria? What's the prevalence rate?
Now, prevalence is determined by a population level survey.
Yes.
We last did a survey in 2019.
Yes.
It put the average, national average at 9%, but varying. Places like Igezi, Kampala are about 1%.
All right.
And Kole at about 3%, Toro at about 4-5%. Yes. But you go to Karamoja, 34%, West Nile, 23%. However, another way of measuring the burden, which is if there are people with fevers, what proportion of them test positive
for malaria?
Right now, almost 6 out of 10 people who have fever will test positive for malaria. Also, the other way we measure it is of all people who visit an outpatient clinic.
Yes.
How many end up turning malaria? Traditionally, it is 30 to 40%.
Yes.
Right now, it is over 50%. So, we would say overall, malaria has increased.
Okay.
Whether it increased because of COVID or not, we don't know. Okay. There are several factors.
Yes.
Yeah, we cannot just blame it that focus has been on COVID.
Yes.
We cannot make that conclusion.
Okay.
Yeah.
All right. So which areas in Uganda are highly affected by malaria?
Right now, for what we call upsurge, which is increase.
Yes.
Because we both watch size and increase.
Yes.
In terms of transmission of malaria, the worst is Karamoja, followed by West Nile and Busoga. In terms of increase, unexpected increase,
yes,
the worst is east, parts of Busoga, and mostly Bukedi region.
Yes.
And then right now, Bunyoro region with epicenter in Kakumiro. That is increase, unexpected increase, yes, from what is expected of that place.
Yes. Well, in a recent interview, you did suggest that what has contributed to the resurgence of malaria in Uganda is due to 2 new species of mosquitoes that are a lot resistant to the treatments and the insecticides and that people are using in their homes. Is that true? You did attribute it to the Anopheles stephensis and Anopheles arabaniensis.
Yes. Now, Anopheles stephensis is an urban mosquito.
Okay.
It has actually not been discovered in Uganda.
All right.
It is more in the Horn of Africa.
Yes.
Eritrea, Ethiopia, Djibouti there.
Yes.
We are really hoping and praying that it doesn't come here.
Yes.
Because urban areas are low in malaria.
Okay.
If it comes, it is able to breed in urban areas.
Okay.
You know, small containers we throw around. You know,
yes.
it can breed in it, and
where the stagnant water can collect it. Yes, is that
yes,
it?
yeah. Even in our water tanks,
yes.
It's going to complicate the issue, the situation in urban areas. Yet we are urbanizing very fast. Uganda is now almost 30% urban,
yes.
and it's going to increase. So it hasn't come. Now, Arabiensis is not new. We have 3 common mosquitoes.
Okay.
Common, there are very many. We have Gambi, we have Phenestas, we have Arabiensis. Arabiensis bite people from outside the house.
Okay.
Now, you see, most of our control is inside the house. We normally, in the evening, we run away inside and close the door.
Yes.
Or we spray the house. You
yes.
cannot spray outside. You will be spraying the atmosphere.
Yes.
So, the population of outside biters increased. Yet we are not putting control outside. So it is complicating the issue. The other thing which has happened is Phenestas also increased. Phenestas bite inside, but their breeding can be supported by very small environmental changes. And then the other thing which has happened is Gambiensis, which feeds inside and also rests inside.
Yes.
Decided now it comes, bites, goes away outside. So when you have sprayed your wall and you think you are waiting for it to sit on the wall and pick a chemical and dies, it comes straight, bites, goes back outside. Out. Yeah. So this complicates our targeting. You know, we are targeting them on the wall and indoors. They got to know we have deployed equipment there.
Yes.
They have changed behavior. So this is what we are really worried about.
Okay. And what about treatment? Because there are some reports that people say, allegedly, I don't know if it's actually true, but thank God you're here to confirm it. Some people are saying that they are gaining resistance towards the treatment of malaria drugs. Is that true?
Now, we have challenges to the common effective anti-malarial, that is artemisinin-based combination therapies. Clinicians over the years have complained of treatment failure.
Yes.
Not resistance. They are different. Treatment failure is you give someone medicine, you expect something to happen within a certain time, it doesn't. It can happen for so many reasons. Compliance, how they take it. For example, Coartem has to be taken with a fatty meal, which may mean a glass of milk, which many people cannot afford, or they store the medicine badly. But unfortunately also, we have actually confirmed genetic markers, which I should say genetic footprint of developing resistance.
Yes.
In actual clinical practice, it has translated to delayed clearance.
Yes.
Yeah. So that the malaria may persist longer than we expected.
Yes.
Except in one region, in Tororo, in Masafu, we have seen this phenomena up to 10%.
Yes.
But meaning 90% still work.
Yes.
In the rest of the country, it is 2%, 3%.
Yes.
But we are doing a surveillance to establish the actual extent, and we are working on measures to prolong the life and the effectiveness of this medicine. Okay. And which needs really good clinical practice, which needs also good compliance from the people, so that we can preserve this tool longer.
Yes. All right, Doctor. Now let's talk about the vaccine. Dr. Ruth Acheng did state to the members of Parliament that next year the Ministry of Health wants to start rolling out the first malaria vaccines. Everybody's question is, how effective is it? Is it working? Because it started in 2019, and then it was a trial program that was done in Malawi, in Ghana, and in Kenya, and it said that they reported about 50% effectiveness of the drug. But still the concern is, one would like assurance. How effective is it?
Yeah, indeed, as you said, what was done in Kenya, Malawi, and Ghana is actual field situation test. This vaccine showed it has capacity to some extent to prevent malaria.
Yes.
But most importantly, to prevent malaria transitioning to severe forms.
Okay.
So even if it can prevent it, if you get it, it remains mild.
Oh, right.
And therefore, if it remains mild, it does not kill. But up to about 50%. Okay. That means 50% will still have to depend on other things. But that is when it works alone. When it works in combination with other things we do, like use of mosquito nets, spraying, early care seeking, yes, then the benefits are more.
Yes.
So it comes to supplement, to work synergistically with other interventions which we already have.
Yes.
We are really very excited at the opportunity of the malaria vaccine.
All right. And will this vaccine be free? And from what ages will it start being administered?
Now, the vaccine has been designed for under 5 children.
Under 5.
Because for malaria, if you live in an endemic place and you have got some repeated infections,
yes,
you develop some partial immunity. But the children, when they are born with some circulating antibodies they acquired from their mother,
yes,
if the mother had partial immunity, which clears in the first 5 to 6 months.
Yes.
So we would like to start protecting them from 6 months, so the vaccine will be given for a new birth cohort.
Okay.
Okay. So those at 6 months, 7 months, 8 months, and then we repeat a booster,
yes,
at 18 months. Where exactly, because the manufacturer at the moment is constrained with the ability to make, they can make only 20 million vaccines for the world.
Yes.
So there's going to be a sharing criteria, and we know Uganda is going to get just about less than a million.
Yes.
Uganda receives about 1 million children per year, but
in birth, those are births?
In births, yes.
1 million a
about
year.
1 million, yes.
Oh,
we are
wow.
very fertile.
Oh, indeed we are.
And we are very active.
Yes.
And they need 3 doses,
okay,
in that first year. So that means only about 1/3 of the Ugandan children born in a year,
yes,
will benefit in the first year. But the manufacturer is working on expanding capacity, including technology transfer.
yes,
And we are hopeful that by 2025 they can be able to make more, and then we can expand the children who can benefit from this.
all right. Well, also Dr. Rutha Chen did say that the vaccine, and she does confirm with what you say, that it's in short supply and only 10 countries will be able to access it. Now let's talk about prevention while we wait for 2023. How can we prevent malaria? You did say that now the mosquitoes have gotten very clever and they're now waiting for people from outside their homes.
Yes.
How can we prevent the spread of malaria from outside our homes?
And now this is very, very important question. You see, people have left the prevention of malaria to government, which is where the mistake is. The government only gives you tools like mosquito nets, sprays your house. It is you to utilize these tools.
Yes.
But there are behavioral things beyond use of the tools.
Yes.
If you must be out and go for an outing, you wear a long thing. If you want your legs to look nice and keep them out,
yes,
you wear a repellent.
yes,
Okay?
yes,
you wear a repellent. If you must be home, you close the doors. By at least 4, 5 o'clock, the mosquitoes don't get in.
yes,
Because the mosquito net will only support you when you are sleeping.
Yes.
It's a tool while you sleep.
yes,
But the rest of the time you are in the sitting room.
That's
If the
true.
doors are open, they come in. But I would like really to look in the camera and tell people, we have a lot of other dangerous flies and animals in our house. Who controls them for us? Who controls for us house flies? In fact, if a house fly is seen at your dining, people know your sanitation is poor.
That's
you
true.
feel even embarrassed. You straight away look for the source of that and you deal with it. Who controls for us cockroaches?
That's ourselves.
Ourselves.
Not the government.
Not the government.
Yes.
Who controls for us mice, rodents, and rats? We do all sorts of things to trap them, to poison them.
Yes.
So why have people allowed mosquitoes to dwell in their house? Not only dwell in their house, but to feed on them, to milk them, to suck their blood.
Yes.
It is like allowing worms in your tummy to suck your blood.
Yes.
No, is that not yucky, really? Is that not? So I would like people to decide that mosquitoes should not think they are farming us. They think for them they are coming to bleed their animals the way we bleed animals.
We go and milk cows.
Yes, the way we go and milk.
They're doing the same thing to us.
That is what they are thinking,
Yes.
and we allow it. Sophisticated as we are as humans, how can we leave this tiny thing to defeat us, give us disease on top of milking us, and kill our children? Yeah. This is the point.
Yes.
Actually, we should be embarrassed when we get malaria. It means you're allowing mosquito to feed on you.
Yes.
Should be embarrassed. Yeah.
All right. So, Doctor, the president did make a comment and did say that why has it taken long? He asked the question, why has it taken long, about 35 years, to come up with a vaccine for the malaria, for malaria, and yet other new diseases that have come a lot recently, for instance, the COVID-19 have vaccines, created for them almost immediately. What could be the cause? Why has it taken it this long for malaria vaccine to be created?
So the president is very right. And he challenged the scientific community. Why are you not finding solutions, technological solutions to these things? There are two dimensions. One is the level of priority malaria has. Malaria does not pose the danger of global health security.
Okay.
It is a tropical disease. It needs blessed countries like us with rain, with good temperatures, with green. Yeah. Mosquitoes survive best at temperatures of about 26.
Yes.
So there are certain parts of the world where scientists are, where funding is, where it's not a big problem.
It's not their problem at all.
And when they come here, they're on prophylaxis. They take Malaron. They wear repellent. So they have taken care of themselves. But also, developing a malaria vaccine is more technologically complex compared. Malaria is a parasite. Right. So it is multiple cells, very complex. Meanwhile, viruses are just a small genetic material with a small protein coat.
Yes.
So there are very few antigens you can target. Malaria, you target this one, it's not effective target, so it's very complex. Also, bacterial infections are just one cell. Okay, they are bigger than viruses, but they're just one cell. So it took a very long time. We are happy eventually this vaccine is approved for use. There is a second one, R21.
Yes.
It's moving very, very fast. It is more promising. In fact, the fact that COVID vaccine was developed very fast, the malaria people woke up, and also advocacy increased.
Yes.
That how come this one you even gave it emergency use authorization, but you are leaving this other one to go through endless regulatory processes?
Yes.
Let's allow it also to move, and we save life.
Yes.
So it's going to move faster.
Okay.
Yeah.
The other concern was the side effects of the vaccine of malaria, because a lot of people did complain, and one of the members of parliament, that is Honorable Amero, did go on to say that children did face a lot of complications and side effects with the rubella vaccine and also the COVID-19 vaccine. So what about the malaria? The side effects, that's
now the good news,
yes.
The good news, and we are really very excited about this, is it doesn't have much side effects. It can give some fevers, just like any vaccine. It can give some mild rash and maybe small pain at the site in very rare cases.
Yes.
You must have read the reports from Kenya here, our neighborhood. So it has been found to be relatively safe. All pharmaceutical products can harm if not delivered correctly. if not, but they are designed to be and tested rigorously for over 30 years.
Yes.
First for effectiveness and for safety. It has taken 30 years to develop this, this vaccine. The benefits, where it prevents severe malaria, where you need a drip, you will need to be transfused. You can get acute kidney injury. You can get respiratory distress and go on oxygen. It's not comparable to those small fevers you get. Yeah.
And a lot of people don't know that malaria can actually get that serious, because people just associate it, oh, I have a headache, I have a joint pain, and I'm just feverish. And people don't understand that it can actually even bring you to a place of a transfusion or even damaging your kidneys. That is how serious malaria is. And I must say that we have all, we as a country have relaxed. Yes, we have relaxed in the fight against malaria. We have not been taking it seriously because there have been something else of global emergency, as you stated, in the COVID-19 pandemic. But then also, I would like to ask, what are some of the biggest challenges that we have faced, aside for us not taking it seriously as a country in the fight against malaria?
Now, right now, the biggest challenge we are facing is blood.
Okay.
Traditionally, malaria-induced anemias use 30% of the blood we collected in this country.
Yes.
Right now, it uses over 50% because we are getting a lot of severe malaria, and many of them are presenting with anemias and tea-colored urine.
Yes.
There's been a very big pressure from the east, people dying while waiting for
the blood transfusion.
Yeah, and also blood transfusion services are facing challenges. The other time schools were closed for a long time. Schools are our target for collecting blood because they're in one group. You go there, you get many.
Yes.
And also the children are relatively safer. They have not got the problems we adults have.
Yes.
There is less chance that their blood is infected. Schools are critical nowadays. They rarely allow people to come in.
Yes.
Because they say you may bring other diseases to the school and the school will get closed. But we are keeping on negotiating with them. Also, the cost of blood collection has gone very high because it is so fuel-based. You know, they have to drive in the field.
Yes.
Yeah, but we are working on that. The other thing is we are getting a lot of acute kidney injuries. Yeah, and fortunately, maybe with COVID, we put a lot of high dependency units and ICUs, but this can only be known by specialists.
Yes.
The biggest challenge we have is people take malaria for granted. So they say, I will treat tomorrow. It gives time for it to progress to severe forms. Some clinicians also take it for granted. Some people in drug shops and small clinics don't refer even when they have seen danger signs because they want to first make money.
Yes.
And the kids especially are brought eventually to the regional hospital when it's very difficult to rescue them. This is the challenge we have. Delay in seeking proper care when we can handle it quickly.
All right. And lastly, Doctor, I'd like to ask you to please share with the viewer some of the most effective ways that they can prevent malaria themselves. Because we only know sleep under a mosquito net and then maybe spray an insecticide. But what other ways can we, protect ourselves against malaria and also protect our homes against malaria?
Now, mosquito nets, we have over-promoted it, and we ended up limiting the options. We are in the bed only about 6 hours, 7 hours. Mosquitoes used to bite from 10 to 5 o'clock. They have extended their times.
Yes.
Some bite even during the day now.
They're working overtime
They're working overtime. Now, the biggest risk right now, again, I'm looking in the camera, is travel. When you leave the comfort of your house, which you have screened properly, you have sprayed we don't move with our mosquito nets. But we pack our masks, we pack our condoms when we travel. We forget to pack our mosquito nets. Then when we go to hotels, and we are working with Hotel Owners Association to make hotels safe. So when we travel up country where there's more malaria, we pick it, and then we bring it to the homes, and the mosquitoes pick from us, harm our children. The next thing is we forget the house help, those who are living in the boys' quarters. So they are the storage of malaria. We are taking care of the main house, which is a mistake. Take care of the whole home. Take care of your neighborhood, because mosquitoes don't respect the boundaries. They fly over all the fences. So we need to conceptually increase. Beyond mosquito nets, the most dangerous things in our houses right now is our water tanks.
Yes.
The water tanks are not covered. The mosquitoes are breeding right there in your gutters, where there is dirt collecting and water accumulates there. So we would like you to have a whole environmental, whole community, whole travel outlook. The other risky thing is the schools and the dormitories.
Yes.
Okay. Because as we send our kids to school, let's send them with mosquito nets, with repellents. Let's support schools to spray, and Ministry of Education has picked this up. So when you have PTA meetings, think about making the schools safe, because 20% of our children are in boarding schools.
Yes.
Yeah. So we would like to expand it beyond mosquito nets to simple things like screening our windows, closing doors, wearing repellents, planting repellent plants around our houses. So a holistic 360 outlook. But should we get fevers, we test quickly, we treat, we complete the dose. Don't treat 1 or 2 days and keep the balance for the next episode.
Yes. when you start feeling better, and then you're like, now I don't need to finish the dose. What about self-medication? Because a lot of Ugandans are in the habit of self-medication, and we also don't have any restrictions when you go to the pharmacy. Anybody can walk into a drug shop and get what exactly, and even not just that, get any drug without the person at the counter asking them questions for, a referral from a doctor or a prescription from a doctor. What about that? Does it also affect us in the long run when we are trying to actually now start to, treat the disease?
First of all, that's how we are screwing up the medicine. And there is no option. We self quinine, we self chloroquine, we self fancida. Chloroquine has not recovered. Quinine is so toxic. The other medicine in development is still in phase 3. We are promoting this resistance development because of the way we use the medicines. We store it at home. We take when it is almost getting denatured. Okay, so the disease is not well exposed to good concentration of medicine, and it develops the resistance. The way ticks have developed resistance.
Yes.
So self-medication is a problem. I was in Kakumiro last week. I found really serious issues, but theirs is access to facilities. You may have to work 6 hours to reach a facility in Kakumiro. So people have, and you have to spend 20,000 to hire a boarder to go to it.
Yes.
So people have devised the means. Once they know NMS has brought medicine, they fake sicknesses, they collect and keep at home. And then when they feel anything, they start taking, and they take both antibiotics and anti-malarials, because they are not sure, is this fever due to a bacterial infection or due to a malaria infection? So they take both.
And does that work?
You overload yourself. There could be drug interactions. The scientists are even thinking it could explain the tea-colored urine, which we're going to expose to more research. So people don't want to get expert support, and they want to suit it with a broad spectrum thing. You take many medicines just in case. Just in case. Just in case one of the things is the issue. But it was for a good reason that we recommended that anti-malarials should be off-counter. Because malaria is so rampant, we wanted people to access care.
Yes, yes.
But that privilege is being abused. You know, you put things for the good reason to help people.
Yes.
They decide to do something else,
So,
unfortunately.
Yeah. So, Doctor, you have also been highlighting something throughout this conversation. You've been saying that we are not storing our medications the right way. So what is the proper way to store your medication? Or should you even have medication in the house?
Yes.
Let's even start there. Should you be having medicine in the house, or
Yes.
you should just...
We should have the following medicines in the at house. First aid kits.
Yes.
They are very basic. Stored properly.
Yes.
In safe locations.
Okay.
Where temperatures are okay. 2, we can store medicines for chronic diseases. If you're HIV patient, you are given a medicine for 1 month, 2 months, 3 months. If you have pressure, you have diabetes.
Yes.
So these people with chronic diseases are actually trained on how to keep their insulin,
yes,
how to keep their metformin. They are trained, and they have good boxes to safely put them.
To keep the medicine the right temperatures.
At the right temperatures.
Yes.
Those which you need to refrigerate, like insulin, they are also taught. So we should limit it to 1 month, 2 months, 3 months stock.
Okay.
But keeping for just in case should only be for first aid. And the understanding of first aid is a rescue, and then you go for expert
yes,
consultation, and
yeah,
then you get the continuation.
Yes.
Yeah, that is the advice.
All right. Okay, thank you so much, Dr. Jimmy Opigo. But before I let you know, any closing remarks that you'd like to share with the viewer?
I would like to emphasize this. We are facing malaria upsurge in the country. Diseases are transmitted in communities, in homes. Prevention of diseases is in individual responsibility. Professor Omasua said, health is made at home and only repaired in health facilities when it breaks down. Health facilities are garages. When we fail our maintenance work, it is our individual responsibility. Let's wake up to the responsibility. It's a lifestyle issue. It is part of life that we take care of ourselves, the way we take care of our relationships, the way we take care of our finances, the way we maintain our homes, the way we maintain our vehicles. We are being advised to go for a 20-point check of vehicles, and we religiously do it. When did you last check yourself? When did you last check yourself? When did you go to a garage to check yourself?
Yes.
Do you take care of yourself carefully the way you don't want to bump your car socks in the potholes? Do you actually? Or you think your body can be exposed and treated to any socks? Think about it.
Yes.
It's all up to us.
Exactly. Thank you so much, Dr. Jimmy. And like he said, please, your health is your responsibility. Take charge. And when it comes to malaria, protect yourself outside just as much as you do it on the inside. Inside your home, you also have to take your protection outside. Carry your mosquito nets when you travel. Carry insect repellent when you travel or when you leave the house. And wear covering clothes. So the people who like to go out, and have, entertainment in the night, please make sure you are covered, because mosquitoes will also attack you from there. Well, thank you so much, Dr. Jimmy.
Please.
And he's a medical doctor, a public health expert, a malaria specialist, and he's the manager of the Malaria Control Program and also the Assistant Commissioner at the Ministry of Health. Well, that is all I had for you on this segment of the Twitter Jabs too. But keep on watching Sunrise at Sea, because we have more coming up, and coming up is our views, so don't blink.